I'm Said Abisi. I'm consultant vascular surgeon from Guy's and St. Thomas's Hospital in London. I'll be talking today about the inner branch technology outcome, which is something we have looked at recently in our practice. So generally speaking, complex endograft, including the inner branch, are designed to treat aortic aneurysms. And these aortic aneurysms have different types. And often these complex endografts are to treat aneurysm where the disease extends above the abdominal aorta to where the aneurysm is located near the renal vessels or the visceral vessels, but also when it extends to the thoracic segment in terms of thoracoabdominal aneurysms. So fenestrated and branch solutions are very good, but they have certain limitations. In fenestrated in particular, it requires precision of planning and deployment, and these can be challenging if you have infrarenal or aortic angulation, where the vessel deformation can change the success rate of deploying these stents accurately. So it's very much dependent on accuracy, lack of angulation, and good access vessel as well to treat the target vessel. While branch technology is also excellent, but requires wider working lumen, which is not always available in all aortic aneurysm we treat. Also, it requires long aortic coverage and thus correlated to the increased risk of spinal cord ischemia. Hence, alternative solution might be necessary. So inner branch technology helps to overcome one of the challenges of traditional fenestrated and branch. First, they are versatile. They can allow you to get into the target vessel within a wide range of location. It also helps to manage these vessels where the trajectory of the vessel is unfavorable for standard fenestrated repair, for example. Uh, Also very useful for shortening the length of the bridging stent compared to standard branch EVAR, allow us to work in a narrow aortic lumen, which is not possible with the standard EVAR. The other advantage is the ability to be designed to reduce the aortic coverage compared to standard branch EVAR. Finally, I think one of the main advantages is the ability to design the endograft based on inner branch technology to treat certain type 1 endoleak after failing EVAR with a short main body. Those cases traditionally complex to plan when you do fenestrated cuff or inverted limb. And having inner branch endograft with integrated limbs on the body helps to reduce all this complexity. So we aimed in our study to look at all the patients we're treating as a large practice with fenestrated and branch, and we identified certain criteria where we felt solution like inner branch might be favorable. All these criteria are discussed in our study. Out of those patients, we selected that those might be better with inner branch, and we looked at them, followed up these patients to see their outcome. So we included all patients we treated in the last couple of years, and that's about 110 patients. And the method was specific criteria against fenestrated repair, like as I mentioned before, unfavorable target vessel trajectory, or the presence of adverse feature or angulation in the aorta. We also identified these patients who had narrow lumen for traditional standard EVAR, branch EVAR, or those who we would want to reduce aortic coverage because it was unnecessary to have extensive coverage if we treat them with a standard branch. So that was a method. We looked at the outcome, the patency, the aneurysm exclusion. We also looked at things like procedural data to determine if this technology is feasible, easy to apply. And this was a focus of our method. Results were very promising. We had early outcome with an average of 1 year follow-up for 18 patients in the study. And all these patients who remained in the follow-up had excluded aneurysm, patent target vessel. We also looked at our procedural data, and they are very comparable and promising. It's clearly the technology is easy to use, particularly in this super selective, very complex case where if we apply traditional fenestrated repair or branch repair, it would have been a challenging case. So our procedural data and outcome in terms of fluoroscopy time and contrast volume, etc., that were very promising. So the conclusion that to make here that it is a it's contemporary treatment, but it's also complementary to what we have already. We have to be cautious and we have to select patients. We clearly treating different diseases with different designs and technology, whether fenestrated branch or inner branch. And our conclusion that this seems to be promising, but we still need to monitor very closely, select very cautiously, because it's relatively new technology. We had it only for a short time. And I think the main limitation is the lack of long-term data. And that's why until this becomes available, we wouldn't be recommending these to be used in every case. So this is one of the main limitations for this technology at the moment. There are a number of options to treat aortic aneurysm. Varies from open method to different ways of complex endograft and standard endograft. What we have to remember, we are treating different patients with different needs and different anatomy. And it's important to tailor the treatment and the device to fit all patients rather than have a fixed way to do things for all patients. This is the beauty of having a number of options and adding to our option that we would always look to select from a variety of devices and methods to treat our patient to what work for the specific patient, that specific anatomy. And I think this is very important because rather than when we think of fenestrated only or branch only or open surgery only, there is no one size that fits all. Different patients have different needs.